Asthma is a chronic disease of the airways that makes breathing difficult. With asthma, there is inflammation of the air passages that results in a temporary narrowing of the airways that carry oxygen to the lungs. In an inflamed airway of an asthma patient, the airway experienced reduced lumen diameter, blood vessels filled with immune cell infiltration. Excess mucus was produced and contracted smooth muscle with inflammation and swelling. Fluticasone furoate, FF. It is a synthetic trifluorinated corticosteroid, and this is the chemical structure of FF. Fluticasone furoate is modified from fluticasone propionate. It has higher affinity, longer half-life and suitable for once-daily administration. The precise mechanism of FF is not known. Corticosteroids reduce airway sensitivity and inflammation. They are also crucial in preventing long-term damage from chronic inflammation, which can cause scarring of the airways. The pharmacodynamic of drug was shown by hypothalamic pituitary adrenal axis effect. In both healthy and patient group, none of them have significant decrease in serum or urinary cortisol level. After absorption of the drug, it would be delivered into the lung. The mean volume of distribution of drug is 661 liter. FF will be metabolized and cleared from the body by the liver. Finally, FF will pass out from body by feces. Before introducing into human clinical trials, the candidate drug has to go through a series of preclinical studies. Preclinical studies were conducted on cell lines and animal models. In vitro studies were conducted on human lung epithelial cell lines to study the anti-inflammatory activity, protective effects, selectivity, and retention activity of fluticasone furoate, FF, with other glucocorticoids, GC, available in the market. The study concludes that FF shows the highest potency, greatest protective potency, highly selective, and bind into a greater degree, as compared with other GC. In vivo study was conducted on ovalbumin-induced asthma rat model to study the anti-inflammatory effect of FF. When FF was given intratracheally, at a dose of just 30 microgram, it was essentially, completely, inhibited the lung eosinophilia in the brown Norway rat. After that, FF entered clinical trial. Phase 1 trial was conducted to investigate safety, tolerability, safe dosage range, and potential side effects of FF. It involved 20 participants, those with clinically stable persistent asthma, screening pre-bronchodilator, FEV1 greater or equal to 60%, and non-smoker were involved. On the other hand, pregnant or nursing females, and those with history of life-threatening asthma, are excluded. The trial participants were randomly assigned to experimental or control groups. From the findings, FF was well tolerated by trial subjects. So, FF is safe to proceed to Phase 2. Phase 2 trial investigate effectiveness, optimal dose required and short-term safety of FF. The trials were double-blinded randomized studies to evaluate morning versus evening dosing, the timing and frequency of dosing, and the frequency of dosing with once daily doses or twice daily doses. The results suggested that either morning or evening dosing was reasonable and a once daily dosing frequency was appropriate. Then, 8 doses of FF, ranging from 25 to 800 microgram once daily, were evaluated to compare once daily dose of FF. Subjects were uncontrolled at baseline on treatments of medium doses, low doses or non-inhaled corticosteroid therapy. The primary endpoint was the mean change from baseline in trough FEV1. As a result, a dose-related increase in trough FEV1 at week 8 was seen for doses from 25 to 200 micrograms, with no consistent additional benefit for doses above 200 micrograms. To evaluate dosing frequency, FF, 200 micrograms once daily and 100 micrograms twice daily was compared. The results supported the selection of the once daily dosing frequency. The most frequently reported adverse effect for Phase 2 is upper respiratory tract infection, sinusitis, headache and cough. FF. Proceed to Phase 3 trial in order to generate statistically significant evidence and confirm the safety and effectiveness. The trials were multi-center, double-blinded, randomized and placebo-controlled clinical trials conducted for 24 weeks in subjects aged above 12 years old with persistent asthma. The trials were designed to evaluate the efficacy of FF given once daily in the dose of 100 and 200 micrograms on lung function in subjects who were not controlled on their current treatments of inhaled corticosteroids or combination therapy. The study showed the improvement from baseline in trough FEV1 with difference of 77 ml for FF with 200 micrograms. Another trial evaluated the efficacy of FF 200 micrograms with a standard treatment fluticasone propionate FP 500 micrograms twice daily. The study showed the improvement from baseline in weighted mean FEV1 with difference of 70 ml for FF. Subjects receiving FF 200 micrograms once daily had a statistically significantly greater improvement in 2 days without the need of emergency medication. Besides, lung function improvements were sustained 1.5 days from the baseline. FF 200 micrograms also show 64.8% reduction in rate of exacerbations per patient per year. Adverse reactions of FF include nasopharyngitis, headache, oral candidiasis, sinusitis, bronchitis and coughing. Based on findings of the 3 dose-ranging trials and 4 confirmatory trials, FF finally gets approval from FDA in August 2014. This drug is patented by GSK Pharmaceutical Company. FF is still under prescription, as it legally requires a medical prescription to be dispensed. Currently, Phase 4 trial is still ongoing to evaluate the benefits, potential risk, optimal use, and studies in specific populations, which involve a larger population.